are the tools that I'll be using for today's exam. Hi there, my name is Tanya, and today I'll be performing an advanced GI examination. Do you have any questions?
No.
Okay, to prepare for the GI exam, I'm going to have the patient lie in a supine position as I stand on the patient's right side. For a general abdominal examination, I would begin with inspection, then auscultation, percussion, light palpation, moderate palpation, then deep palpation. For an abdominal examination on a patient with complaints of pain, I would percuss and palpate that area last and as tolerated to minimize guarding. I'll begin the exam by inspecting for special signs. For Cohen's sign, I would assess for ecchymosis around the umbilicus. A positive finding is bruising around the umbilicus. This is a classic sign of a ruptured ectopic pregnancy or acute pancreatitis. Next, I will assess for Gray-Turner sign. I would assess for ecchymosis of the flanks. A positive finding is bruising in the flank areas. This is a sign of acute pancreatitis or retroperitoneal bleeding. Next, I will inspect for abdominal distension. Causes for abdominal distension include fat, fluid, feces, fetus, flatus, fibroid, a full bladder, and fatal tumor. Next, using my stethoscope, I will auscultate bowel sounds in all 4 quadrants, using the diaphragm of my stethoscope. Starting with the right upper quadrant, the left upper quadrant, the left lower quadrant, and the right lower quadrant. Bowel sounds are present and normal in all 4 quadrants. Cause for abnormal finding on auscultation include absent bowel sounds, which may indicate peritonitis or an ileus. Also, hyperactive bowel sounds, which may indicate gastroenteritis or GI bleeding. And lastly, high-pitched tinkling bowel sounds, which may indicate an obstruction. Next, I will assess for abdominal aortic aneurysm. Using the bell of my stethoscope, I will auscultate the aorta for bruits. Next, I will palpate to estimate the size of the aorta using both hands. The estimated size of the aorta is 2 centimeters. Findings that may indicate an abdominal aortic aneurysm include a pulsatile mass or an estimated aortic diameter of 3 centimeters or greater. Next, I will assess the patient's liver. I will begin by percussion of the liver span. Starting in a tympanic area, I will percuss upward until dullness. I will now mark the skin. Now I'll percuss down until dullness. I will now mark the skin. The liver span is 10 centimeters. Expected or normal findings of the liver span is 6 to 12 centimeters. Next, I will perform the scratch test using the diaphragm of my stethoscope. I'll place the stethoscope below the xiphoid process. I am going to scratch upward until I hear the sound more loudly. I will now mark the skin. Now I'll continue to scratch up until I hear the sound less. I will now measure the distance. The distance is 9 centimeters. Expected or normal findings is approximately 10 centimeters. Next, I'll perform deep palpation of the liver. Am I taking in a deep breath? Findings are normal. Abnormal findings include if I feel more than the liver's edge, and also a hard, irregular liver. Next, I'll examine the patient for ascites by performing a fluid wave test. Can you place your hand in the middle of your abdomen? I'm going to palpate one side as I tap the other. Findings are normal. Abnormal findings would include if ascites is present. I would feel fluid shift from one side to the other. Next, I'll assess for Murphy's sign. I want you to take in a deep breath as I palpate the gallbladder. Okay. Findings are normal. Abnormal findings would include if the patient abruptly stops mid-inhalation due to pain. Next, I'll perform an exam of the spleen. I will begin with percussion in the lowest intercostal space in the left anterior axillary line. Now, I would like for you to take a deep breath in. Okay. Findings are normal. Percussion may change to dullness as an enlarged spleen is pushed down under your finger by the lungs. This would be an abnormal finding. Next, I will deeply palpate the spleen. I want you to take in a deep breath. Okay, now release. Now I want you to take in a deep breath as I turn you to the right side. Okay. Findings are normal. I would suspect an enlarged spleen if I felt more than the edge of the spleen. Next, I will assess the patient. Next, I'll perform special tests for peritoneal inflammation and appendicitis. I will begin by assessing for McBurney's point. I'm going to go 2/3 of the way between the umbilicus and the ACES. I will now palpate McBurney's point. Do you feel any pain?
No.
Tenderness or rigidity may indicate appendicitis. Next, I'll assess for Rosving's sign of referred pain. I'm going to deeply and slowly palpate the left lower quadrant. Are you experiencing any pain?
No.
A positive Rosving sign would include if the patient felt pain in the right lower quadrant as I slowly and deeply palpated the left lower quadrant. This would suggest appendicitis. Next, I'll assess for rebound tenderness. I'm going to slowly and deeply palpate the left lower quadrant and rapidly lift. Do you feel any pain?
No.
A positive rebound tenderness sign would be if the patient felt pain in the right lower quadrant as I abruptly lifted my fingers after deep palpation in the left lower quadrant. Next, I'll assess for psoas sign. I want you to resist against my hand by lifting your leg. Okay, did you feel any pain?
No.
A positive psoas sign would be if the patient felt pain in the right lower quadrant as I pushed against their right leg. This would suggest appendicitis. Next, I'll assess obturator sign. I'm going to internally rotate the patient's right hip. you feel any pain?
No.
A positive obturator sign would be if the patient felt pain in the right lower quadrant as I internally rotated the hip. This would suggest appendicitis. Next, I'll assess the patient for kidney tenderness. I'm going to have you sit up on the side, towards that way. This is the costovertebral region. I am going to percuss for CVA tenderness. Do you feel any tenderness?
No.
Tenderness would suggest possible pyelonephritis. This concludes my advanced GI examination.